Hello, I'm Connie Lehman. I'll be speaking on artificial intelligence and imaging. These are my disclosures. AI in medicine, where will we take this? During this session, I look forward to sharing with you my perspective on what a promising future I think AI has to tackle some of our most challenging problems in breast cancer early detection and risk assessment. First, some terms. There's a lot of discussion about AI, machine learning, deep learning, and they're all related. And also, they're all related to CAD. CAD, in fact, is really just computed-assisted detection or computed-assisted diagnosis. These are also terms used by the FDA. CAD is part of the whole field of artificial intelligence, which has been with us for quite some time. Machine learning tends to incorporate human engineering. So for example, a program might take features of calcifications and masses that humans have recognized as highly suspicious for cancer and program that in to machine learning models. These are many of the older CAD models that we're familiar with. With faster computers, we then moved into the domain of deep learning. This is unsupervised learning. This is learning that isn't guided by humans' perspective or perception or engineering on what cancers might look like on a mammogram, but the computer actually learning on its own. We've leveraged the strength of computer vision and brought that over into the imaging sciences, and that's been an exciting time for all of us. So for quite some time, there have been computer vision deep learning models that take many, many images of cats and dogs and train through deep neural networks, very fast computers, to distinguish the difference between a photo of a cat and a photo of a dog. The computer is actually learning. In this time that we have together, I'd like to focus on three specific topics. When I think of all the deep learning tools for screening and risk prediction, we have tools for detection, diagnosis, for breast density. We have new tools coming out to help mammographers triage, to separate high from low risk mammograms, to maybe act as a second reader, to use different paradigms for image review. This may even be a road to eventual autonomous AI interpretation of screening mammograms. We also have deep learning models to predict the future risk of cancer in 1 to 2 years. This may help us be more refined in our recommendations for screening that's more targeted, not just based on a woman's age, but actually on her profile and her risk of future cancer. So we can move into more sophisticated methods of determining the appropriate interval and whether or not supplemental imaging will help each individual patient in screening mammography programs. We also have deep learning models that are looking even further out into the future, 5 years out into the future of future lifetime risk. So it is these three domains that I'm going to touch upon in the talk today. I think it's so important that the UK National Screening Committee commissioned a team of investigators to review and assess AI algorithms, both alone or in combination with radiologists, to detect cancer in digital mammograms. They intensively reviewed 12 studies published between 2010 and 2021, about 130,000 screened women in the compilation of these studies, and they found that 34 of the 36 AI systems that they evaluated were actually less accurate than a single radiologist, and all were less accurate than the consensus of 2 or more radiologists. So they urged for caution. They noted how many study designs are retrospective, that there's a high risk of bias based on cancer-enriched samples being used, the well-studied reader study laboratory effect, differential verification of outcomes of patients across the studies, and insufficient follow-up. And they concluded, and others have agreed, that the specific biases of the studies will more likely lead to overestimation of sensitivity and underestimation of specificity. And in fact, we've been here before. CAD applied to mammography was approved by the FDA in 1998. With reimbursement, the use rapidly increased across the US. Multiple study designs were used in the early phase, but just like now with AI, these were mainly retrospective reader studies. Very small single-site prospective studies were reported with mixed results on the impact of CAD on the accuracy of mammographic interpretation. So we evaluated as soon as we could the actual performance of CAD in real-world practice. And what we found was that there was no improvement in digital mammography performance, the interpretation of digital mammograms with CAD out in actual clinical practice. So this was really a warning cry that what we see in the laboratory may not translate over into clinical practice. So we now have an opportunity to learn from our past, new opportunities for diverse applications to address some of our greatest challenges. And I truly believe one of the greatest challenges that we have in radiology is human variation in image assessment. We reported on this extensively. It's a challenge in multiple healthcare domains. We just study it really carefully in mammography. So in one study looking at screening mammography performance and interpretation, we found that more than 40% of radiologists have abnormal interpretation rates, what we often think of as recall rates, outside the recommended ranges, and more than 37% fall below recommended ranges for specificity. And this has an impact. Not only do those false positives lead to unnecessary anxiety and recalls and studies for patients, but also the cost of these false positive mammograms is significant. So what I'd like to do now is show how we took a deep learning model to improve clinical care. I'm going to use breast density as an example because it's one of the few domains where we have the full cycle of model training, testing, implementation, and post-implementation evaluation in real prospective clinical practice. So we knew that it was a significant challenge. The FDA had proposed mammography changes for the first time in 20 years to identify breast cancer early. This was thanks to the very successful advocacy effects of the Are You Dense campaign and other similar organizations saying women really deserve to know what their breast density is. And it seemed to make sense. We know it's easier to find cancers on women with less dense breast tissue than it is to find cancers on women with more dense breast tissue. And women with increased breast density are more likely to have a future breast cancer. So it actually increases their risk of cancer. Unfortunately, just as I showed with the interpretation of the mammograms, we also see wide variation in radiologist assessment of mammograms as dense. The Prosper Foundation, with Brian Sprague as the lead, and a group of us reported on 83 radiologists. And it was really remarkable, the variation in how radiologists interpreted mammograms as dense. They all had to have at least 500 mammograms evaluated to participate in the study. At one extreme, 6% of mammograms were read as dense by one radiologist. At the other extreme, 85% of mammograms were read as dense by another radiologist, and everything in between. And this wide range of assessing mammograms as dense from 6 to 85% is clearly not informing women in the way we want to of their true breast density. So we built a model. We trained our deep learning model to assess breast density based on our academic Mass General breast imagers assessments of breast density, where there was much more consistency than we had seen in other studies in other domains. We found 97% of agreement with expert readings in test setting and 94% agreement with human readers in routine clinical practice. So then we wanted to bring it out into the clinic. Brian Donchos shared this research that he did at our site at Mass General at ASCO recently. And what Dr. Donchos did was he took over 85,000 consecutive screening mammograms from two different time periods. One period in 2017 when no one was using the deep learning density model, and another period in 2019 when two sites had been using it for some time. One site was a predominantly academic site, and the other was a community practice. That gave us the opportunity to compare the impact on breast density assessments after implementation of our deep learning model in routine clinical practice. So what did we find? Well, we were pretty excited because what we found that the site, our community practice, which is represented by the green line, had wider variation in their density assessments, and they tended to assess more women as dense as we did, as represented by the red line, at our academic center. We had a more narrow band of variation, and also we tended to have few of our mammograms that we would assess as dense. But once we implemented our deep learning density assessment model and trained our community practice radiologists how to use it, we found there was no longer any difference between density assessments by our community practice radiologists and our academic radiologists, and the variation had also decreased. What was even more striking was when we compared to our third site, Site C. This was a community practice that hadn't implemented the deep learning density model. They actually started off in 2017 assessing significantly more of their patients as having dense breast tissue, and they increased the percent of patients over time assessed as density. So by 2019, it was getting close to 70% of all their patients that came through for screening mammography were being told that they had dense breast tissue. Now, if we were to take this narrowing of the human variation as we saw by implementing our deep learning density model, if we could translate that over to the findings that we had in the Prosper study by Brian Sprague, think of how tightly we could operate within a more appropriate level of breast density assessments. We could bring that wide variation from 6 to 85% down into this very narrow range, which is a much more appropriate range to be in almost all screening mammography practices. This would be more consistent for women. It would remove those fluctuations from year to year, bouncing back and forth from being dense or not dense, or just, depending on who interpreted the mammogram, a woman is guided towards supplemental ultrasound or guided away from supplemental ultrasound. So the impact could be quite large. And it's really looking at that variation, that narrowing the variation, so taking many humans that have many different reactions to breast density and bringing them down into a more narrow sphere. So the red boxes are 2017, where Site A, the academic center, had a lower density and a tighter window of range of densities, and how that improved by the turquoise box in 2019. And again, the variation, so seeing that variation at Site B in the red, the 2017, decreasing in 2019. And at the practice that never adopted it, there was a lot that was going on in 2019. Different ways that people were recommending that density be assessed, because there was an inclination to provide more options for women for supplemental imaging. Some radiologists were trying to push the density up just to give their patients more options, but at the risk of misinforming them of their actual density. So we saw at the site that did not put into the density model in their practice a dramatic widening of variation in density assessments. We're also hopeful because we think this type of construct, using deep learning models to reduce human variation in many different domains with modern technology, will be so important. This is a graph I like to show because it shows human variation in interpreting screening mammograms, whether they are 2D, as represented by the open circles, or the closed circles, digital mammography plus tomosynthesis. Now, this study was widely celebrated for the impact that tomosynthesis could have on increasing cancer detection and reducing false positives. But if we look at it, these 13 different lines look a bit like pickup sticks, and it just shows the wide variation across 13 centers performing large volumes of screening mammograms. It also shows, if you compare the closed circles to the open circles, that the transition from the open circle 2D only to the closed circle tomosynthesis mammography, that transition wasn't consistent across all sites. There are actually some sites that increased their recalls. There are other sites that actually, there's a bit of a detrimental effect on the cancers per thousand after they started to implement tomosynthesis. So the modern technology is great. I'm a big fan of tomosynthesis when used correctly. Frankly, when CAT is used correctly, it has the potential to really improve the overall performance of mammography. But human variation is still so wide. What we're trying to do is leverage the new tools of deep learning to bring us more into where we'd all like to be. So wouldn't it be great if with deep learning, we could take the value of tomosynthesis, but bring everyone into the red circle, into an area where you have a high cancers detected per 1,000 and a very low patients recalled after screening. So the last area that I'd like to discuss, and I hope that we have a lot during question and answers also, is the area of deep learning models applied to risk of cancer in 5 years, or the future lifetime risk of patients. So how did this come about to be? Well, we've always been interested in trying to change our current paradigm of mainly age-based screening to risk-based screening. But what held us back was we really hadn't developed accurate, equitable, feasible risk assessment models for large populations of women. We certainly had made some progress, and yet we all agree our current methods to assess breast cancer risk do not provide equity across races and across ethnicities. And we all agree much stronger risk factors need to be discovered. So we've been studying this pretty carefully at Mass General, and one thing we discovered was that if we looked at the populations that we are assessing risk on, and I'm going to give as an example Tyrer-Cuzick version 8, 5-year risk and lifetime risk, when patients are labeled as high risk by either of these models. And we looked at the distribution of our patients that are assessed that way. We found that 26% of all of our white patients being screened in a very large Mass General system, we screen about 50,000 women a year, 26% of our white patients were labeled as high risk by the Tyrer-Cuzick 5-year risk score, and just over 12% were labeled as high risk by the lifetime risk scores. This was dramatically higher than what the percentages that we saw of our Asian populations, our African American populations, and our Hispanic populations. Where with our Asian patients, for example, the 5-year Tyrer-Cuzick 8 risk, only 12% of Asian women were put into that category, 12% of African American, and less than 9% of our Hispanic patients. This has dramatic differences in who then has access to enhanced care based on their risk profile. We certainly aren't the first ones to note this. There's a fantastic article in the New England Journal, August 2020, labeled Hidden in Plain Sight, Reconsidering the Use of Race Correction in Clinical Algorithms. And this is across many different algorithms to predict future risk of diverse diseases, from renal disease to cardiac disease, and in these two examples that they provide, to breast cancer risk. And what they conclude is that these risk calculations return lower risk estimates for women who are African American, Hispanic, Latina, or Asian American. And the equity concern is that because these return lower risk estimates for all non-white race ethnicity categories, this is potentially reducing the likelihood of close surveillance in these patients. My colleague Leslie Lamb, by the time we're all at San Antonio, will have presented this last week at the Radiologic Society of North America 2021 meeting. And what Dr. Lamb identified was that white non-Hispanic women are 2 to 3.5 times more likely to be classified as high risk compared at Mass General to our patients of color and patients who are Hispanic. Yet we found no difference in the cancer rates, the cancer burden within these two populations. Traditional risk models we knew were built on European Caucasian patient populations, and they use inputs that are heavily weighted by social determinants. I think this is at the crux of the challenge that we have with our traditional risk models. So these models, at best, have AUCs of 0.6, 0.63. That is in overall populations, and we look at them in subgroups, in other races and other ethnicities. They can perform even worse than they do in European Caucasian women. So we were curious if we couldn't develop deep learning models that would extract more than just density. Couldn't we extract the full spectrum of signals embedded in the individual woman's mammogram? We started with almost 250,000 exams and over 80,000 patients. A classic approach that we all take in deep learning is that you have your training set. You then set aside exams into your testing set and your validation sets. And neither the testing nor the validation sets will ever be seen in training by the deep learning models. We reported in Science Translational Medicine, our AI image-only risk model performed better than traditional models, and it supported equity across races. We then evaluated our 5-year deep learning breast cancer model across 7 diverse practices globally, from Brazil to Asia to Europe and within the US, including at Emory, where almost half of all patients being screened there are African American. And we found very consistent AUC scores in predicting 5-year breast cancer risk, all within the range of 0.68 to 0.72. And this was very consistent across diverse races and diverse ethnicities, both within and outside the US. So I'd like to highlight that we're really seeing AI and deep learning applied to mammograms in 2 distinct domains. The first is what we think of more with traditional CAD. A radiologist reads a screening mammogram with the assistance of traditional CAD might see a lesion that the radiologist might have otherwise overlooked. So there's many domains with deep learning and AI that we can address as mammographic interpretation, whether it's assessing the image quality, the density, detecting lesions, or actually diagnosing them, not just flagging a lesion, but giving and predicting the risk of cancer of that specific spot on the mammogram. And then the entire domain of triaging. Could we have a roadmap to autonomous interpretation because we could identify a subset of mammograms that have such an extremely low risk of malignancy, they do not need further human evaluation. Then the second level is what I show along the bottom. These are the 5-year traditional risk prediction from patient-reported inputs, the Gale model, the CRA Health model, the Tyrer-Cuzick model. Could we, with deep learning and AI, move into a domain where we have these 5-year plus AI risk prediction from deep learning image-only mammogram inputs? So we're hopeful that this is a new approach to risk assessment that is more accurate, more equitable, more efficient, and inclusive. The image-only model supports patients with unknown family history of prior breast cancer, and we really believe that this may open the door more equitably and accurately to more women to have access to risk reduction and prevention strategies. We also think that AI and deep learning will be the tools that will bring the imaging sciences fully into precision health. It is extraordinary to see the advances that have occurred in genomics and that will continue to occur with the strength of deep learning, which is all about taking big data and analyzing it in ways that we just couldn't before we had these fast computers. We also think AI-assisted radiomics will predict risk and guide more targeted interventions for the full diversity of patients. And these AI models may in fact be synergistic with the genomic models that we already have. It's very exciting to consider the possibilities there. So going forward, I firmly believe that deep learning provides us with tools to address our greatest challenges for our patients worldwide and to amplify our impact in image interpretation, density assessment, and risk assessment. New tools of deep learning may allow for, in fact, new paradigms in screening for improved access to high-quality, equitable, and precision health at levels that we haven't been able to accomplish previously. I want to thank my colleagues in Boston, without whom this work would not be possible. Extending our impact and improving patient outcomes in new and transformative ways guides our vision and our work together. And thank you for your time and attention.